Welcome, Dr. Langer. You're on mute, so we can't hear you.
Hi.
I got it now.
Hi, how are you?
How y'all doing?
Hi.
Thank you.
Perfectly.
All right,
Thanks.
perfect. Well, Dr. Langer, welcome to the group. I so appreciate you taking the time today to be with us. We're honored to have you. As you know, I'm Angel. I started Meningioma Companion, also known as Brain Tumor Companion, back in 2020, and it's a place for peer-to-peer support. Everyone in this room has a different condition on this journey, and we're just excited to talk with you and ask you questions that we have. Lots of us are fans. We've watched your show, Lenox Hill. Some of us can't stomach to watch it, but maybe someday they'll get there. But in the meantime, I thought that I would just open the floor with you to introduce yourself and tell us why you chose neurosurgery.
Yeah, both my grandfather and my dad were doctors, and I really never, as a little kid, I don't remember ever think of, want to do anything else. Like, thinking back, I probably should have thought of doing something else, but frankly, my personality and my sort of ethos works really well being a physician. So I think I ended up choosing wisely. I think the only other thing I thought about doing was being a marine biologist because I love the ocean. And then I once went to a fish store and I built a fish tank, and the salesman said, "Don't be a marine biologist. You'll end up like me in a mall selling fish." Like,
Okay.
all right. But the journey to neurosurgery was a little bit more difficult. I always tell college students or med students, the hardest decision to make is what kind of doctor you want to be, not so much to go to medical school. It's there's so many different options as a doctor. So I originally thought I wanted to be a cardiologist like my dad. Unfortunately, my dad had a stroke the year before I started med school, and I kind of, was my real sort of personal introduction to neurological disease and deficits and things like that. And I got grew very comfortable with, people with deficits. A lot of times when people have a deficit or a stroke, they experience significant social and personal difficulties. They get, it's common for people to lose friends. People feel uncomfortable in their presence. So I learned pretty quickly the kind of vagaries of a neurological deficit. And when I got to medical school, I didn't really like internal medicine. I found it to be kind of boring. I was a rower in college, and it wasn't really a team sport. I liked this OR, like the pace of it. It was almost like an athletic thing. And, I really enjoyed the residents that were doing this. They were happy. I thought about being a cardiac surgeon. And I was pretty sure I wanted to be a cardiac surgeon for a while, but the guy I was shadowing was always in the hospital, was divorced. And also I was worried about stents taking over the cardiac surgery business. So I went to neurosurgery ultimately because I just sort of loved the whole idea of it. I saw two of the residents putting a ventriculostomy into a patient in the ER, and CSF came flying out of the person's head. I was like, I got to do that. And unfortunately, I became a vascular neurosurgeon, and then I got divorced, and I'm in the hospital all the time, and stents took over vascular neurosurgery. So you never know. So I in the end, all worked out. I'm really blessed and lucky. I have a great life and a great job and a great group of people to work with, and I can't complain. So there you go. But look, there were obstacles, there were difficulties. It wasn't straightforward. It was a bit circuitous. It's like I'm sure all you here have had obstacles yourself, and it's not the obstacles that define you. It's how you overcome them and how you make these things positive thing in your life. And I think that's the biggest lesson I have.
Absolutely. Thank you so much for sharing. Impressive stuff. And I speak for all of us in this room when I say that we appreciate people like you with your drive and your discipline to do this type of medicine. Obviously, we're all big fans, and we want to open the floor to the room so that everyone can introduce themselves and give you a brief idea of who they are and what their question is today. And I'll just start with Kelsey.
Hi, Dr. Langer. My name is Kelsey Knapp. I'm from Frederick, Maryland. I was experiencing vertigo, which I thought was related to my anti-seizure medication. And it turned out I had a brain tumor on the left side of the cerebellum, close to the brainstem. And I am now 2.5 years post-op, a 98% resection. And it turned out to be a phelocytic astrocytoma. I'm probably saying that wrong, so I'm sorry. My neurosurgeon and neuro-oncologist believe now, due to my positional vertigo I'm still experiencing, they both seem to think maybe it's an inner ear issue. My neurologist thinks maybe, okay, well, if there's a little piece of the tumor left in your brain, it could be the scar tissue or the tumor still causing that. My actual question is, what would you do if you saw a surgeon on your team about ready to make a mistake during surgery?
Well, I work with, I'm the most senior guy in my department, more or less. And, I often operate with residents or junior attendings. And there's a difference between operating with a resident who you're more or less telling what to do, or you stop them much earlier. I can't say that, there are very few times you're going to, see someone actually make a mistake almost until it happens, because most of the people I work with are excellent. And, I've made, what you would call as a mistake, rupture an aneurysm, or, accidentally injure a cranial nerve or something like that. In general, it's kind of a team sport. And when we know we're dangerous, we go more slowly and, stop and look around. And there's a certain forbearance we have when we're in, a certain position. It's more like telling people to slow down and, whoa, that I would stop there, something like that. So, but usually you're aware of the danger zones, and we know where we can operate quickly and safely and where we can't. And that's something that's, we talk about in the OR, and there's sort of a recognition when you're in one of those situations. So it's not that a person can make a mistake, what you would call a mistake, but, so often there are, it almost happens before you have a chance to stop it when that happens. But in general, there's feedback. That's why operating with a good, a partner is really valuable. I use the exoscope. So with the exoscope, the entire room can see the operative field. Very often, one of the residents or even the PA or even the scrub tech will say, "Hey, Dave, do you see that?" And I think that that's a valuable thing to have, even whether I'm assisting or operating, that, everybody contributes to the case. And it's the wisdom of crowds. So there's a certain element of skill, luck, and creativity that goes into this, and you have to just accept the fact that sometimes bad things happen that are beyond your control.
Thank you.
As far as your tumor goes, unless that residual tumor is in a location that can't be removed, you got to keep a close eye on it. That get MRIs really frequently, because polycytic tumors are curable with surgery if you remove the whole thing. So if there's residual, just got to keep an eye on it, because the last thing you want to do is that to convert into a more aggressive tumor. So you should be getting frequent MRIs, and if it's in a place that can be removed, it's something you should consider, certainly if it grows. So that's the only other thing I would say.
Thank you, Doctor.
Yeah, I stay on top of the MRIs for that reason. Thank you.
Thank you. Next up, Brenda.
Hi, I'm Brenda, 41 years old, from Arizona. A little over a 1.5 years post-op of a left frontal lobe. I don't know if I'm going to say this right, but oligodendroglioma, grade 2. My journey began February 2019. I was backpacking and my right leg just stopped functioning. I was able to get out, but it took me 3 neurosurgeons just to get an MRI, which they discovered the low-grade glioma. I had 6 weeks of radiation in conjunction with chemotherapy, then 6 months of the maintenance chemo. Last December, I started having absent seizures. And my question is, do I stand a higher chance of recurrence since I started having seizures after my tumor was fully resected?
No. I mean, the brain, you just have scar there. If the tumor is fully resected, that has may have very little to do with your seizures. Once just opening the head can induce a seizure. It's just irritating the brain. And then when you go into it, you have to, get around the tumor. So there's the area of the brain. The seizures are caused by the neurons, in the vicinity of the tumor cavity, not so much the tumor itself. Very often, tumors can induce the seizures because they're irritative. But if they did a complete resection, the seizures have nothing to do with the risk of the tumor or the tumor recurring. It's really just the irritation, the scar that's left behind in all likelihood. And, unfortunately, that's the price you pay. But with good medications and good surveillance, you ought to do quite well if they got the whole thing out and you've gone through that treatment course. It's, it potentially is curative depending on the genetic signature of the tumor. So you're lucky in that regard, but you just have to hopefully stay on meds, and this may calm down over time and completely go away. You never know. You're still pretty early.
Awesome. Thank you.
You're welcome.
Thank you. Next up is Lori.
Hi, I'm Lori from Fairbanks, Alaska. I was diagnosed with a meningioma in November 2021. Saw a neurosurgeon in January, Dr. Fix in January 2022, and I'm currently on watch and wait because it's small right now. She is currently treating me for neuropathy, and I was recently diagnosed and had surgery for breast cancer. So my question is, can my meningioma be related to my breast cancer or vice versa, since it is hormone driven?
Yeah, I mean, meningiomas are more common in women anyway, and men don't get breast cancer nearly as well. They can get breast cancer actually, but it's very uncommon in men. So we see this. We see women with meningiomas and breast cancer. And certainly there are meningiomas that maintain hormone receptors it's a similar thing with breast cancer. There are estrogen and progesterone receptors. There's no real connection that we know of. I don't think your meningioma is more likely to progress because you have breast cancer, or is more likely to occur because you have breast cancer. So you're kind of lucky you have two diagnoses. That's just your dumb luck. But luckily, the meningioma is benign. In all likelihood, it's, the only thing that we sometimes do is people that have breast cancer and we see a tumor, they can mimic a Met. And so, sometimes you can say, oh, there's meningioma, and then you got to make sure you do an MRI at 3-month intervals for the first year, because a metastasis would grow quickly, whereas a meningioma wouldn't. So as long as you're, keeping an eye on it, because metastases can mimic meningiomas. They can look very similar to them. But just keep an eye on it. If it remains stable, I wouldn't touch it. And then if it starts to enlarge, especially at your age, I would, in that location, is probably safe to remove.
Thank you.
Thank you. All right. Next up, Christy.
Hello, I'm Christy. I'm 36 from Teaneck, New Jersey. After years of
close.
yes, very close, very close.
I lived in Tenafly for a couple of years when I was a kid. So
did you really? Oh,
I did.
Small world. After years of symptoms and almost going blind last year, I had an MRI that showed a large 7-centimeter tumor, like right here. It was actually so big it was pushing my skull and actually formed a bump and had been reshapen. My tumor was very vascular, so I underwent an angiogram 24 hours prior to my craniotomy. Half of my skull was replaced with titanium mesh. They removed like 95% of it, and it was confirmed grade 2 atypical, so I required radiation, 6 weeks. But since then, I'm fully recovered and I feel great. So my question is, since you can't 100% diagnose the tumor grade or even the type of tumor without surgery, how do you differentiate meningiomas from other types of brain tumors?
Well, preoperatively, they have certain characteristics and appearances on an MRI. Other things can mimic meningiomas, and sometimes we make mistakes just pre-op. But in the OR, they have a very, there's a usual configuration. They behave a certain way. And then, you can send a frozen section, and when you find them, to confirm it. It's very uncommon to get in there and then be mistaken. Either way, most of the time we're not operating on things that don't need to be operated on. So if it's something, we usually wait till something gets bigger or causes a neurological deficit. When in your situation, such a large tumor in your age has got to come out, especially in light of the bump and losing vision. So there's no question you'd operate on it. But there are times where we see tumors that we think they're meningiomas, and like Lori talked about, where we think they're meningiomas and we can't rule out another problem. So repeat another MRI, say 3 months. But if it starts to grow, that's uncommon for meningiomas to grow that quickly. And so if a tumor grows quickly, our threshold to remove it drops. Whereas most meningiomas, year to year, if they grow a few millimeters, that would be a lot. There are some that grow faster, And in that case, we remove them. If sometimes they're very indolent and quiet and they don't present with a neurological deficit, like it took a long time. I mean, 7 centimeters is a big tumor. Whereas, if say you picked it up with a headache or something, 5 years ago, it probably was there. And we could have taken it out earlier had we known about it. So what pushes up to operative meningiomas are either a neurological deficit, size that causes, edema in the brain, or a cranial nerve deficit, or serial enlargement. Those are really the reasons to operate on a meningioma, because frankly, if they don't grow, just leave them alone. It's just like, there's no reason to operate on something if it's not causing any problem, if it's benign. And things that are not benign grow more quickly. So if you think it's something and then you choose, oh my God, in 3 months it grew twice the size, and you operate on it, and it's not a meningioma, it could be something else. That's really the way we deal with them.
Thank you.
You're welcome.
All right.
I can't be you didn't come to Lenox Hill for your tumor. I can't understand it.
What?
You didn't come to Lenox to have your tumor taken out. I can't stand it.
Well, hopefully there will be a next time. So I'd love for that to be a one and done.
Yeah.
All right. Next up is Karen.
Hi, I'm Karen from San Leandro, California. And it's nice to meet you, Dr. Langer. Thank you for your time today. About 4 years ago, I was having some issues, and with an incidental finding through an MRI, I was diagnosed with a front temporal lobe meningioma. So I'm currently on watch and wait. But my meningioma and diagnosis with cervical dystonia at the same time caused me to resign from my job in healthcare. I was working in administration. So being on watch and wait the last 4 years, I'm currently researching gamma knife surgery over an invasive surgery like a craniotomy. So my question is, what are your recommendations for a specific procedure for someone like me who's been on watch and wait for 4 years? What would you recommend?
I mean, if it's not growing, I would leave it alone. Now, what side of your cervical dystonia on?
It's on my left side.
What side's the tumor on?
My left side.
Okay, so the tumor has nothing to do with your dystonia. So that's good.
No.
And I think in your case, what I would do is how old are you?
I'm in my late 50s.
Yes, I mean, you're young, at least in my opinion, you're young. I think that I would follow this just like you are, and then I depending on the tumor, if something can be removed safely with surgery, I would err on the side of that rather than gamma. We do gamma knife usually on patients that have small tumors that are in difficult locations that are growing. But to use gamma knife on a case that can be removed safely, especially, meningiomas grow from the surface covering of the brain, or the midline falx, or at the skull base. And without seeing your film, it's hard to say exactly where it is, but usually these tumors are very safe to remove. And that if it's my family, I don't think I would want to use gamma knife as something that could just be removed, safely and with low risk, because gamma knife does have side effects that can be hard to control. It doesn't mean you shouldn't do a gamma knife if it's the right size and configuration of the tumor. But I'd rather take the risk profile of a cranie most of the time, and risk that I can control, versus the secondary effects of radiation, which can be difficult to manage. But in general, you have to go to a good neurosurgeon that can talk to you, frankly, about the individual risks. Then it's really your decision. And without seeing your films, I couldn't, surmise exactly those individual risks. It may be appropriate to recommend gamma knife in your situation, but respect the fact that sometimes just because something's less invasive doesn't mean it's less risky. That's something that I think is lost in translation, whether it's in with tumors or with spine or vascular. Everyone thinks, well, if I don't open my head, that's more safe than a catheter or a radiation, whatever. It's not necessarily the case. And in good hands, most of the time, meningioma surgery is quite safe. But in general, I would leave you alone as long as the tumor's not growing. And I wouldn't just radiate it just because, if it's not growing, it's not growing. There's no reason to treat it. If it starts to grow and you're in your 50s, you're going to live another 40 years potentially. I would treat it early if it started to grow. I wouldn't wait, till it was twice the size before I treated it. And that's the way I would approach that problem.
Okay, great advice. Thank you so much. Appreciate it.
Thank you. Next up is Deneen.
Hi, Dr. Langer. My name is Deneen, and I'm from Baltimore, Maryland. It's a pleasure to meet you. I had a golf ball size meningioma removed from my left frontal lobe in August 2019. I developed hydrocephalus, and now, as of March 2021, I have a VP shunt. I already had a defective valve, and it was replaced, and the new shunt is currently overdraining. Unfortunately, I've required 3 adjustments so far. My neurosurgeon thinks we're on the right, headed in the right direction, but my symptoms are difficult to endure. My question is, how successful have you seen the use of shunts in patients with hydrocephalus?
I mean, that's the only way to treat them. That you can't manage hydrocephalus without a shunt these days. So by and large, 99% of the time, shunts are not only the only treatment, but they're very effective. What symptoms are you having now from the shunt? Headaches?
Yeah, headaches, some dizziness, mostly headaches are the main problem.
You have an adjustable valve shunt in?
Yes, I do.
Do you know which one?
It's a Certus Plus.
That's what I use. I mean, these can be sometimes some people, a small percentage of people, and I mean small, you're just unlucky, have to have a very narrow range that they seem to feel good. And, sometimes you just have to, manage the valve. If you're not doing, do you feel like you're overdraining now? Like what's happening to your size of your ventricles? Do you know what your scan looks like?
He said the ventricles are a little smaller. And so he just readjusted it about a week and a half ago to it's at a 5. It was at a 3, and then it was overdraining. So he went to a 4, and now I'm at a 5.
Yeah, 5 is where I usually start, just as an aside. But the good thing about the Certus stuff, you can essentially turn them off. If you can go up to I think up to 8, and then you turn it up higher, and it's as if they doesn't work. So, if you're really suffering from this thing, you can just raise the shunt pressure so that it essentially doesn't function, and you can see how you do. Sometimes hydrocephalus, especially after a tumor removal, is temporary. It's really caused by some protein or some, just the act of surgery. Some blood gets into your spinal fluid pathways, and your absorption mechanisms are disrupted. But there's some people who probably don't even need the shunt. So if you're still suffering from over drainage symptoms, even at 5, then I would just continue to raise the valve pressure and just see how you do, and follow your ventricular system. Ultimately, if they turn all the way up to 8 and you're fine, then you leave it there. I wouldn't necessarily remove it because there's risk of taking it out, but that's kind of the way I would plan. And you just, if you need it, you need it. That's the point.
Right. Okay. Thank you very much. I appreciate it.
You're welcome.
Thank you. Next up is Patty.
Hi, Dr. Langer. It's a pleasure to meet you. I'm a 38-year-old female from San Francisco Bay Area. About 7 months ago, I was diagnosed with a tuberculum sella meningioma. It was actually thought to be a macroadenoma. It's grade 2 atypical. I was having 2 weeks of headaches, vision changes, and anxiety. I went to my PCP, then to the ER. I was hospitalized, and 3 days later, I had surgery through an endonasal approach. I had a very complicated ICU stay, 18 days. I've had many post-op issues, including rapid regrowth of my tumor nearing my optic apparatus, partially encasing my carotid arteries and in my cavernous sinus. I did 28 fractions of conventional radiotherapy and 5 fractions of CyberKnife boost. I experienced severe radiation side effects. I now have panhypopituitarism, continue to battle with extreme fatigue, nausea, dizziness, brain fog, exercise intolerance, resulting in a very poor quality of life for me. I still have not returned to work. My question is, have you ever seen pituitary function return after obliteration from radiation?
I haven't. But luckily, we can give you pituitary supplements, which I'm sure you're very aware that as disruptive to your life that is, at least it's not something that can't be treated. It's unfortunately, you're describing the downsides of radiation. It's just like I was, explaining to, was it Karen? About this is the trouble. I mean, I think with an atypical tumor, you're sort of forced to do it because they're without radiation, they'll grow right back. Also, an endonasal approach, if, obviously they didn't think it was an atypical tumor. If you knew it was an atypical meningioma, they might have done an open operation to start. Again, less invasive doesn't mean it's safer. I don't love the endoscopic approach for meningiomas, but for pituitary tumors, we do them all the time. So, if it masqueraded as pituitary mass, then that's just unfortunate. You have to sort of tough it out. I mean, the longer you go, these symptoms will likely improve, some of the side effects. And the key is that you cure the tumor, that, you don't want this thing to grow back. And especially around the cavernous sinus, that's a tough spot to kind of, contend with, just because of, the risks of, if it starts to grow back, you've already been radiated. And so you really can't, hopefully it won't, because the next step would be an open operation if it really began to affect your vision or was growing in the cavernous sinus around your carotid. And that can be that's a big operation to treat that. So, I think you absolutely, it sounds like you had the right treatment given the diagnosis. I just because I haven't seen pituitary function come back doesn't mean it can't happen. And I would be, as brave as you can be and sort of getting through some of the side effects, and respect the fact that sometimes you just have to push yourself and try to, whether it's, do other sorts of exercise, meditation, yoga, all these other things, or there are people have chronic pain. It's kind of like the same thing. And you have to find your the solution to this. And very often the tincture of time really helps. The further you get away from the treatment, chances are you'll improve a little bit, and some of these symptoms will get better. But just to keep your fingers crossed, and I hope you're getting frequent MRIs to make sure that there's no regrowth. That's really the key message.
Thank you so much. I have an MRI next week, so first one since.
Good job. All right, thank you. And next up is Lisa.
Hi there, Dr. Langer. It's a pleasure to meet you.
Hi.
And thank you for being here with us. I am 62 years old, 2.5 years post meningioma craniotomy. 7 months after my surgery, I had an overdose. I overdosed on Xanax. And shortly after that, I was diagnosed with temporal lobe epilepsy. So my question to you is, what is the percentage of your patients that struggle with seizure and suicidal ideation? And do you think that there is enough emphasis on education to the patient and family to the potential problems that can surface later on?
There probably isn't. Although your outcome is uncommon. I think the best answer I can give to that, I mean, unfortunately, you have to operate in these. If the tumor is growing, if it's large, and basically telling people what the rare side effects. I mean, temporal lobe epilepsy or suicidal ideation is uncommon. I mean, it's rare. It's probably less than 1% of the time. And so, if I went through the potential risks for every patient that would include that, it's just, it has to come out. The tumor has to come out. And so it's not something I routinely do. Like I mentioned, depending on the location, yes, I could cause a seizure. I could cause, if it's sitting right on your motor strip, you might have temporary weakness, or it could be permanent if it's really sticky. If it's in a location near the eye or the optic nerve, you could lose vision in your eye, but it has to come out. And so the risks I often really focus on are the ones that have to do with the location of the tumor that are specific to that. Unfortunately, these things happen. Why they happen, I don't know. I think that the education piece is difficult because, it's one thing if it's a purely elective operation that, you don't have to have. And that's that in that case, then I think the onus is on us to be much more candid about all the different things that could happen, because if leaving it alone is totally safe and you can live the rest of your life with it alone, like say like plastic surgery, you don't need it. If you want to have it, there's still risks. And I always talk to patients that there are 4 kinds of operations. Ones you don't have, you can, should, and must have. And when there are operations that you should or must have, then you're sort of at a point where, the risks are the risks, and I can either scare the crap out of you and make you feel really anxious about something that's very low risk, if not infinitesimally small, or I can give you confidence that yes, we have to do this. These are the specific risks of the surgery. There are other risks also that are very low risk, but it doesn't change the fact we have to take it out. Now, if you have something that doesn't need to be done, an operation that you can have, or it's your decision, then I would be much more candid about, look, I don't think you should do this because, if you really want to do it, you can do it, but just respect the fact that there might be a whole set of things that, while they're low risk, if I leave it alone, there's no risk. And that's usually cosmetic things like bump on my head, or, I just don't like the way my craniotomy scar looks or whatever, and I think, and when you're in that category, I think we have to be more careful. So I don't, I certainly, when it's like you, and you do have an outcome like yours, you can go back and say, oh, the way to reverse this thinking is, would you have not had the surgery if you knew that you were going to end up this way? And the question then is, what would have happened if you didn't do the surgery? Would it maybe the tumor would have grown and caused you a neurological problem, or maybe been even more difficult to remove? Mm-hmm. So that's kind of the answer I would give you. It doesn't mean that we're perfect. It just means, I think, as a surgeon, you have to modify, what you tell patients based on your own style, based on the indication for surgery. There can, should, or must. I don't do operations you don't need. And depending on the type of surgery I'm doing in one of those 3 categories, then the risk profile, I determine, like if you must have the surgery, say you're dying, or you show up in the ER with hydrocephalus and you're unconscious, you just got to have not even have that discussion with you. I may tell your family, we got to do this to save her life. But I'm not going to go into the fact that I might cause a seizure. It's just not, it's not in the profile. So, you have to, Matt, you understand that when these things have to be done, they have to be done. We respect fully that there are side effects of these operations, and in the best of hands, things can turn out in a way that we don't expect them. And we all suffer when patients don't do well. It's, I always remember the patient that I hurt much more than that I help. But I think that depending on the tumor, the patient, the location, that really determines how we just discuss, at least in my opinion, the particular risks and what your expectations ought to be.
Okay. All right. Thank you.
Thank you. All right. Next up is Elizabeth.
Hello, Dr. Langer. I'm Elizabeth, and I live in Fort Myers Beach, Florida. I'm retired with my husband down here. 2 years ago, at the age of 69, I fell and suffered a head injury, and I had contributed my balance issues because I have severe glaucoma on my left eye. I've lost the peripheral vision. But it ended up that in the emergency department, they did a CAT scan and found I had 4 Meningiomas. I went for a second opinion to Mayo Clinic, and they recommended surgery before radiation, before gamma knife, since it was causing some major issues. It was pressing against my left brainstem, which was corrupting the form. It was like indented. So they went in and did the surgery, and during the surgery, the neurosurgeon had to call in 2 more neurosurgeons because it was different than what the MRI presented. It was multi-hemisphere and 7 of my nerves were encased inside the meningioma. They did loosen the trigeminal nerve, which now I have trigeminal neuralgia. They decided, they just debulked it instead of, they couldn't remove it all because they said it was connected to the blood supply as well. 6 months later, I had Gamma Knife because they wanted something to control the size because they were afraid it was going to start growing again. I lost the hearing completely in my left ear. I'm on Tegretol and Cymbalta for pain for the trigeminal neuralgia. Recently, an MRI showed that one of my other 3 tumors, the one by my right optic nerve, was starting to grow. And their recommendation was Gamma Knife, and I had Gamma Knife. So there still are 2 tumors in wait and watch. My question to you is, my mother had a meningioma in the frontal lobe and she passed away from surgery complications. Are meningiomas decided that they could be hereditary?
Wow, that's quite a story. I don't think so. I mean, I think it may be just luck that you and your mom had meningiomas. I mean, they're very common. They're the most common brain tumor. They're not really a tumor, brain tumor. They're a tumor of the covering of the brain. They're easily the most common, though, of the intracranial tumors. But it may just be that you and your mom both had a susceptibility to them, and there's basically probably some genetic susceptibility that happens, and they're more common in women. So, you know, it probably just by flip of the coin, you and your mom both had them, and there probably is some association potentially. And if I was your daughter, I'd get an MRI just to do it. You'd rather know than not know. As far as your meningiomas go, it sounds like that's, you know, the first one you had was probably in the CP angle and was involved with the lower cranial nerves, and it extended up to the 5th nerve. These can be really tough tumors to remove. They can bleed a lot. They're very deep. And I think those are some of the most difficult. Petrosal meningiomas are some of the most difficult meningiomas to cure effectively. You know, the fact that it's up against your 5th nerve is why you have trigeminal neuralgia. So when we're in those situations, what we try to do is basically get in there and decompress the 5th nerve to take the tumor off of it. That could be even the most important thing you can do. So if the tumor's still pressing your 5th nerve and you're breaking through, you know, Gamma Knife and medication, it's not crazy to go back and try to decompress the 5th nerve. But with all the craziness you've had with surgery, you know, I would be really hesitant to do that. So it really depends on your quality of life and whether you're getting relief or not. If you're miserable and the pain is just intractable no matter what, and just can't live this way, it's not insane to go back and try to decompress the nerve better. And even just getting in there and taking the tumor off the nerve, which you shouldn't be too difficult, and then sort of doing what's called a neurolysis, like just irritate the nerve a little bit, can really cure or really diminish the trigeminal pain you're having. So it's, you know, I think that you had 2 different problems. One is the Gamma Knife was used to control the tumor growth, but if your trigeminal neuralgia is really a problem, then you just have to decide if it's worth, you know, just doing you don't have to cure the whole tumor, but you want to take it off the 5th nerve. And at the time of surgery, that probably is not part of they didn't know that you were going to have that. So they may have left some tumor there because it was so difficult to remove and it was bleeding a lot. And so that's the only other option that's available. And then you got to keep an eye on the other 2 tumors. Obviously, if they start to grow, they need to be treated. And that's that. If they haven't grown, you know, in the last couple of years, it's a good sign.
Yeah, the one by the right optic nerve that I just had the Gamma Knife grew like 0.3 centimeter in 9 months. So
Right.
that's why they recommended the
Yep.
Gamma Knife on it, because it was growing into the cavernous area.
Yep. Yeah, keep an eye on the other 2.
Okay, thank you.
Perfect. Thank you. All right, next up is Donna.
Hi, Dr. Langer. It's very nice to meet you. I'm Donna from Raleigh, North Carolina. I'm 62 years old, and I had a craniotomy to remove a left frontal lobe grade 2 atypical meningioma in April of 2020 after I was experiencing leg seizures. Never knew you could have a seizure in your leg. So I spent 2 weeks in ICU, and then I was transferred to a rehab facility. They said I had a stroke after surgery and was left with paralysis. So my question to you is, why do you think that happened? And was it because of my age? I've never heard of anyone experiencing this.
Well, meningiomas, unfortunately, if you had you may have had a parasagittal meningioma, which is up against the motor area for the leg.
Okay.
And the tumors can press down on the brain, but if they're large enough, they can be up against some of the arteries that feed the brain as well. They can be sort of associated with them or pressing against them. And it's possible that in taking this out, the small branch or on one of the arteries that feeds the motor strip or the motor area of your leg was injured. And so you may have had a small stroke. Usually, very often, this is well tolerated, but it sounds like you suffered a stroke that, was almost certainly related to a blood vessel that was either attached to the tumor, or sometimes the artery will go right through the tumor, and it gets injured on while taking it out, and then you can suffer a stroke from that. And that's why in talking about the risks in your situation, there would have been a risk of injuring the arteries just based on the MRI, the location. And, unfortunately, once you have a stroke, you can have seizures.
I did.
And it affects the area that's subserved by that tumor, that brain. That's why the seizure was in your leg, because that's the area of the brain was being irritated by the stroke. And, very often that will get better. Once you treat the seizures, you get the seizures under control, some of that spasticity and rigidity in the leg can really improve. And you may always have a little weakness and some stiffness in the leg, but with good physical therapy and rehab, you can really get a lot of functional return. And only to the point that you hopefully you're the only one that recognizes that you have that problem, and you sort of you have it, but everybody else doesn't even realize it.
Right.
But it's unfortunate. That's the worst thing to cause in a person is a stroke. And most of the time we want to get people out in a couple of days. Obviously, if you're in the ICU for 2 weeks, then it's really something went on, and that's just bad luck. And it's just part of the business we're in. So I'm sorry to hear you had to go through that.
Thank you. Thank you. Thank you for the information. I appreciate it.
You're welcome.
Right. Next up is Allie.
Hi, I'm Allie. I'm 36 years old from Nashville, Tennessee. I'm actually 2 months post-op of a left posterior fossil 7-centimeter meningioma grade 1. When I was diagnosed, I was currently going through my second round of IVF. My symptoms came on really quickly, including unexpected dizziness, nausea, migraines, double vision, and inability to walk. Once I was diagnosed with my surgery, I was scheduled a few weeks later. I'm in recovery doing outpatient 4 times a week. My question is, once I do heal, do you think I can continue my IVF journey or even be able to have children at all due to all the hormones related to pregnancy?
100% you can have IVF and do everything. There's if it's a grade 1 tumor and it's out, you're cured. And I think that might have just been true and unrelated. The fact that the IVF may have brought on some symptoms, but it's really the tumor that caused your symptoms, not the IVF treatment, not the hormones. And I think that once the operation's been done, and I wouldn't do it right away, but certainly within I'd say get over the surgery at least 6 months. Okay. And as long as you're doing well and your scan looks good, I don't see any reason to not embark on IVF again. And frankly, there's no real additional risk to having children, and you should live a normal life and put this in your rearview mirror.
Okay, thank you.
Your OB will probably call you high risk if you do get pregnant. And so they'll want to talk to the neurosurgeon. What I would tell the obstetrician is I wouldn't change anything. I would treat you as a normal patient. And if you want to have a vaginal delivery, it's no problem. I wouldn't necessarily consider you high risk. You may have a little bit of a high risk of having a seizure just because of the brain's a little bit irritated. But if you haven't had one yet, the further you get out from the surgery, the less likely it is that you will. So I wouldn't necessarily, while I think they'll probably call you high risk, I wouldn't, consider yourself high risk.
Okay, thank you.
You're welcome.
Thank you. Next up is Maki.
Hi, I'm Maki. Hi, Dr. Langer. Thank you for talking to us. I'm 37 years old from San Jose, California. In 2015, while I was in nursing school, I experienced several focal seizures, and in my MRI, it showed a brain tumor in my right frontal lobe, which was removed that following May of 2015, and the pathology confirmed that it was a grade 4 glioblastoma. I did 6 weeks of radiation and about a year and a half of chemotherapy. Fortunately, I was able to graduate school and graduate and work as a full-time RN and was cancer-free up till 2020. And then I decided to start a family. And within the time I became pregnant, I started having unusual symptoms of vertigo, headaches. I had a routine MRI done without contrast, showed there was another tumor growth on that same right front lobe. And I lost the baby, had another craniotomy in 2020, and I did chemotherapy and radiation right away. My question is, after the chemo and radiation, the tumor regrew within a couple months. So my question is, why did the tumor get outsmarted by the chemo that was treated before? And have you seen any patients diagnosed with GBM that have lived a long life?
Wow. First of all, I mean, you're very lucky. I mean, to live 7 years now from your diagnosis is uncommon. You're already way ahead. And you know, as a young woman with a glioblastoma, that's a lot of pain to carry. It turns out that, you know, recently they've broken glioblastomas up into IDH types. So it turns out that even though histologically it could look like a high-grade tumor, the IDH mutation is thought to be, if you have a wild type IDH mutation, then the outcomes are worse, that you have a classic glioblastoma. If you have an IDH mutant, then you have what's called a grade 4 astrocytoma. It's not really a glioblastoma anymore. So this is a relatively recent classification. The reason was that the IDH mutation appears to be associated with outcome. So if you have a mutant IDH type versus the wild type, which is the sort of base type, if you have a mutant type, the outcomes are significantly better than those with patients with IDH wild. So one question is what your IDH status is. If you don't know it, you ought to find out. You know, I think it's likely you had a mutation that was a IDH mutant. That's why you did so well, and that's why no tumor recurred for 5 years. You know, it's very common for these to break through the chemotherapy and the radiation because that's what glioblastomas do. If it's not crazy to have a third craniotomy. You know, very often if it's safe and there's tumor growth, we're really aggressive, and then we take it out again because that's really the only way to prolong your life and to keep you going. And if it's small, you could continue to live another 5-10 years. You know, you just don't know. But the real question is what your IDH status is. And then the other thing is, can you get into a clinical trial? You know, if you truly have an IDH wild, which is right now, and at least in all our clinical trials, in order to get you in as a glioblastoma, you have to have the IDH wild type. That's a classic glioblastoma. So, you know, with your age and your functional status that you're doing so well, you're an ideal patient for a clinical trial. And so I would, if you have a glioblastoma, everyone with a glioblastoma should be in a clinical trial, period. Because the conventional treatment is really relatively poor. And in any clinical trial, you get the conventional treatment. By definition, you have to get Temodar and radiation. And the clinical trials add some additional treatment that has shown promise for whatever reason. We have like 15 glioblastoma clinical trials at Lenox. You know, in California, there are good places to go for that. So the two things you need to do is, one, what's your IDH status? You should find out from your surgeon. And two, what clinical trials are available to you that might be effective given a recurrence, you know, essentially it's 7 years. And if there's tumor, should you have a third craniotomy to, you know, because debulking the tumor and getting it out is still the best way to prolong life.
Right. Thank you for that.
Thank you.
Good luck.
Thank you.
All right. Next up is Dr. Rod, who's our in-house sleep doctor.
Okay, thank you, Angel, for the presentation. Dr. Langer, it's a real pleasure meeting you. As Angel told, I am a sleep medicine specialist here in Mexico. And 5 years ago, I went into a diagnosis by a meningioma in the falx affecting the parietal motor cortex. It was discovered after a couple of falls, after losing my left arm and left leg strength. I went into two surgeries within a 3 days space. And after that, 25 radiotherapy sessions, finishing by December of 2017. After that, I went into physical therapy required to relearn walking and standing up after a few weeks, passing from the wheelchair to a walker to a cane, and finally walking by myself. But the thing is that as a side effect, the spasticity of my leg is the most common or persistent side effect, which is increased or triggered by very stressful situations like working issues, new places issues, unknown places, for example. And the other one I have, actually that side effect is treated with baclofen as a central muscular relaxant. I'm taking 10 milligrams per day. Also, tinnitus developed is also present, but it's not as hard or as frequent as the spasticity. I'm actually managed with clonazepam, 0.3 milligrams per day, and paroxetine, 10 milligrams a day. My main question, Dr. Langer, is there any recommended besides side treatments for the spasticity or the problem that I actually present after this surgery? It's the main problem that I may have after this almost 5 years after my diagnosis and surgery.
I mean, if it's really compromising you, there are functional neurosurgeons that can put a baclofen pump in. It's basically a procedure where they put the catheter in your spinal fluid space at the level of spinal cord, and it's a little pump that's underneath the skin, and it just delivers the medication into the area of the cord. And I don't do that procedure. More often than not, these are people that are really compromised by spasticity. But if you're really compromised, you have a lot of rigidity in your leg. If you're really stiff, and it's really, and you're not really responding to oral baclofen, it's certainly something to consider. Whether you're a candidate or not for it is up to the doctors that do them, but that's the only other treatment that might be of benefit to you, and that's up to between you and the neurosurgeon. What they often do is they do a trial. They'll put a catheter in that's external, and then they see if it works before they put a permanent implant in. But this is all part of what's called functional neurosurgery. It's basically for movement, like Parkinson's, for people with diffuse spasticity. We're getting, that's the future of neurosurgery, really. It's this functional stuff, which is all based on, very elegant placement of catheters or electrodes in the brain or in the spinal cord that can affect, the functional capacity of people. There are procedures for depression that are becoming to come out, or anxiety. There's even potentially a way to treat obesity with functional neurosurgery. So, it's a burgeoning field, and you have to make sure, if you do consider going to someone, go to somebody that has a lot of experience and isn't going to just do the operation just to do it, and is able to make a determination whether you're a candidate or not. I think that's the most important thing.
Okay, perfect. Great news. Thanks for your experience, and thank you for your answers.
Yeah, that's a great functional neurosurgery. I like that. All right, thank you. Next up is Jen.
Hi, Dr. Langer. I'm Jen. I'm 45 from Buffalo, New York. Ironically, I watched your show about a year before my life changed forever with this whole thing. I was diagnosed last year, April 2021, with a meningioma in my left middle cranial fossa. It's approximately 6 millimeters. It was an incidental finding after months of extreme vertigo and dizziness on my left side. My vertigo and dizziness resolved after a meningotomy, but the meningioma remains. And my question is, I'm told that if it grows, the first function to be affected will be my speech. How does that present in patients that you've seen? And based on your experience and research, how many patients never see regrowth and remain stable?
First of all, if it's only 6 millimeters in the middle fossa, it's probably very mesial. That they usually grow. I have to see the film, but first of all, I wouldn't worry about your speech right now. And these are really safe. I think that if you're not having symptoms and you have a 6 millimeter stable tumor, I would try not to worry too much about it. And if it had to come out, it usually can come out without real risk to speech. That's pretty aggressive to say that that's what it's, because this is so small, and with good surgery, you can pretty much take anything out without affecting speech. There's no meningioma I could think of that size that would be the first thing I'd worry about. But by the same token, going back to some of the other questions, are there risks? Sure. If you somehow injured a vein or an artery, you could result in a stroke or a venous infarction, and then that could cause some speech deficit. But even in the temporal lobe, it's usually not the first thing that happens. And so, by the same token, you have to follow it. If it has to be treated, it has to be treated. I think Gamma knife can be an option with such a small tumor, depending on location. And if there's if your neurosurgeon thought there was risk to speech, it's possibly in a place like that, then if you were treating it, I'd have a lower threshold not to operate if there's truly a risk of losing your speech. But without seeing your films, I think that's pretty unlikely. And I think with a 6 millimeter tumor, the fact that you found it, if it starts to grow, you treat it. And it's so small that the outcome is likely very good. And I would live a normal life and try to not worry too much about it, because in general, these are safe things to treat. And it would be a shame if you, really, impacted negatively about this and on something that you never would have to treat at all. And that's just not, you're only on this earth once. We're living in the moment. Every moment is precious. It's a small amount of time we have. And so, if you let this thing dominate your thinking, it's just not a life to live. And if it really is dominant, just treat the darn thing. There are times we treat patients just don't want to deal with it anymore, and not worry about the MRIs and the risks and all this, because ultimately the risks are usually small, but it's the anxiety and the quality of life that really shouldn't be affected by this. And if it is, and if you can't, it's something you can't, if really affecting you like that, it's just another consideration. Going back to the 3 kinds of surgery, it's a surgery or treatment you can have. It's not a should or a must. And the reason why you can have it is because, it's really affecting your quality of life in a different way. But like I said, without seeing your film, it's hard for me to, give you the breakdown of whether that should be even a consideration. But that happens sometimes. People just want it out, just get it out of me. I don't want to worry about it. And that's, another option that you probably should consider.
Thank you.
All right. Next up is Terry.
Hi, good afternoon, and thank you for your time today, Dr. Langer.
You're welcome.
I'm 55 years old. I live in Sonoma, California. In the summer of 2020, I was having some exertional headaches that were very different than any other headache I had had. Went to my doc, they did an MRI and found a 5 centimeter grade 1 meningioma deeply in my cavernous sinus on the right side. They did surgery. They were able to get about 2 centimeters out. The shape was a little irregular. What's left is wrapped around my internal carotid artery and trigeminal nerve. I have diplopia in the right eye. I lost hearing in my right ear. And I have 24-hour-a-day trigeminal neuropathy with neuralgic features. So far, my neurosurgeon said there's nothing they can do. He does not think that I'm a candidate for decompression of the trigeminal nerve. The neuropathy, I can handle the diplopia. I can handle the being deaf on one side. I can handle my balance issues from the vestibular disruption, but that neuropathy is 24 hours a day. My face feels like it's in a vice. Do you have any suggestions for treatment options that I might be able to consider?
Yeah, like the other lady, trigeminal pain is just, my wife actually has a trigeminal neuropathy. and I've seen what she goes through. It's just, because living this chronic pain is just, it's terrible. I really, my heart goes out to you. I know how tough it can be. And the medications are sometimes half the battle. There are things you could consider doing. Number one, you could gamma knife the trigeminal nerve, and see if it definitely could work. And you have to see somebody who treats trigeminal neuropathy with gamma knife. There are also ablative techniques that are through the face, where you can go to the trigeminal ganglion and do a radiofrequency ablation. So there are, if you're really disabled by this and you're breaking through medications, then those would be the treatment considerations that I would have. This is probably from the tumor and the irritation of the nerve of the tumor. Again, is there residual tumor pressing on your nerve? What does your film look like? Would you benefit from a decompressive operation to take the tumor off the nerve or not? That's something you have to ask your neurosurgeon. But then that's another operation. It sounds like you really want to avoid that if you can. So I would see someone it's in UC Davis or one of the university practices in Northern California, and then talk to their functional neurosurgeon about what the options are. And trigeminal arousal is unfortunately a common problem. You have a unique one because it's related to a tumor, but it's someone who treats those patients frequently that would be the best to determine whether there might be either a non-invasive or less invasive approach to see if you would benefit from that.
All right, thank you.
You're welcome.
Thanks. Next up is Pam. You're on mute, Pam.
There's always something wrong. Thanks for being here for us. I also watched your documentary. I'm 68. Stiffness in my legs also has led me to an MRI that revealed a skull-based meningioma. I was on watch and wait for 2.5 years, elected to have surgery at the Mayo. It was only partially resected due to the location. It's posterior to the lower clavus and anterior to the medulla and lower pons. Post-surgery, it remained stable, thank goodness, at still 2 centimeters by 3.3 by 3.1. After my craniotomy, I was 7 months in the hospital and rehab, had a feeding tube, bad vertigo, and aspiration pneumonia 3 times. I also had to have a shunt due to hydrocephalus. Now I have to have eye muscle surgery. I'm 2.5 years out due to double vision, and I've been doing vision therapy, which has helped somewhat, but not enough. I have to have vocal cord injections because I was left with a paralyzed vocal cord on the left side. And my problem is I still suffer from very, very stiff legs that make it difficult to walk. So obviously, they don't think that my stiffness in my legs was from my meningioma at all. I take baclofen to no avail. I've done therapy to no avail. My neurosurgeon does not think it's from the residual meningioma, and surgery is not recommended again due to the problems I've had. Neither is gamma knife or radiation because of its location and residual size. Neuropathy has been suggested, but it's not addressed yet. I do have an appointment with a physiatrist and a neurologist soon to try to address this horrible stiffness in my legs that scares me so bad. Sometimes I'm so afraid. Could a meningioma, my residual meningioma, still cause this?
In both legs?
Both.
And do you have the symptoms when you're at rest or when you're walking? When do you get the symptoms?
Constantly. There's never a reprieve. Never.
And when you say stiffness, is it pain? You have pain, or when you say stiffness, what does that mean?
Rigidity, stiffness. Like I feel like my legs are stuck in cement. Like I can't move them. And they're so
the first thing
rigid.
I would say is we do a full spine MRI. Just make sure.
I've had that. I have had that.
of your lumbar spine also?
I have nerve decompression. I do. I have compression of my nerves, but again, they said it's not anything that's any different from anybody else my age that should cause all these problems.
You don't have bed spinal stenosis, in other words.
Yes, I do.
I mean, if you have, I'd have to see your MRI, but first of all, for meningioma of the brainstem, which is what you probably had, and you've had some brainstem symptoms with the swallowing and the vertigo and aspiration. This is all lower cranial nerve stuff. Whether they were injured the cranial nerves when they operated on you, again, what had they go? They went like this to get to the tumor. What was the approach?
Craniotomy, nasoendoscopy. Pardon me.
They went in the back.
Yes, in the back.
Yeah.
Up the
so
back
you probably have a tumor that's up against the brainstem. The tumor could be causing the stiffness, causing rigidity, but that's a little. It's possible. It would be odd just to have something in your legs, not your arms, for example. But I really would have to see your film to really determine whether, I thought that was a problem. But it's very possible what you're suffering from is bed spinal stenosis and neurogenic claudication. And if you do have lumbar stenosis and you're having those symptoms, again, if it's really severe, I would have a lumbar decompression because that's safe, and it might help you. I just don't know. I would definitely see a neurologist. Your reflex exam is very important, whether you have reflexes or not. If you've dropped your reflexes, then it's probably lumbar stenosis. If you're hyperreflexia, it's more likely the tumor. So somebody has to examine you. You need and you need an EMG and this kind of thing to see whether you have some sort of peripheral neuropathy. But that's why a neurologist would be really important. It's a little bit odd to have leg stiffness and not upper extremity problems from a brainstem tumor. So I would be very cautious before I did anything. I think it's appropriate to see a neurologist like you are and go from there. And it may be a very simple solution, which would be good.
Thank you so much. Thank you.
Thank you. Next up is Sabrina.
Dr. Langer, my name is Sabrina. I am from Virginia, and my journey started with vertigo in January of 2013. Then I had several episodes of a blown pupil.
Wow.
Yeah, it was an odd thing. My ENT found my tumor in October because I was just going to different doctors trying to find out what was going on because I'd never had vertigo before. And in October, he found it and immediately called in the tumor board and everything. I had the tumor removed in December of 2013. It was a quarter-sized benign tumor removed from the cerebellum and the fourth ventral brainstem. And after diagnosis and testing, it was found to be cerebellar liponeurocytoma. Less than 1% of brain tumor are this. So very, very, very rare. With that, I had, in May of 2014, I developed hydrocephalus. And they treated me with a shunt in August of 2014. I was one of the very, very, very rare people that had to have the shunt catheter drain removed from the stomach and into the lungs because my stomach couldn't stomach it, literally.
Yeah.
That's where I'm at. So my concern is with your history and brain tumors, and I'm 8 years out now, so I've been living with this quite a bit. What vitamins and supplements do you suggest are prescribed for fatigue? Because fatigue's really bad.
I don't think, I'm not a huge supplement guy. I don't think there's any data on any of these things. Okay. On the other hand, I think one of the reasons why maybe if you have a pleural shunt, it can fill up your chest cavity with spinal fluid and you can get short of breath and feel like you just can't, do things. So first thing is get a chest x-ray and see whether there's a lot of fluid in one of your lungs. That might be the reason why you're feeling fatigued because if one whole side of your chest is filled with fluid, your exercise tolerance, you're just going to get short of breath. You're going to feel terrible. Okay. If it couldn't be absorbed in your abdomen, then it's something that there may not be a good solution. There are other places to put the catheter. like in your heart, in the what's called the atrial shunt.
Yeah.
But if there's a ton of fluid in your chest cavity, and your lung is compressed, that can really cause fatigue.
Okay.
So that's number one. The other thing is there are lots of alternative medicine doctors out there. Some of it's just, I think BS, but in good hands, there are some people who give IV therapy for, that might, I certainly would encourage you to see somebody who's reputable. So the question about vitamins and supplements, those are the people to, ask about that. Full disclosure, I had a recent accident, and I went to one of my close friends in Philadelphia, I've had like 4 IVs in the last, a couple of weeks ago. So, I kind of believe in some of the stuff. My feeling is we don't know anything about it, but it's not going to hurt you. And so the worst case scenario is to have expensive urine. But by the same token, definitely get a chest x-ray, definitely see that's contributing to your problem. And if you want to try some alternative treatments, certainly if you can afford, because insurance doesn't pay for it, these things may work for you. And I wouldn't discourage you to do it if it was something, this far out. It's unlikely to get better. So why not?
Now, on your IV treatments, do you take them long term, or you?
I took like 5 IVs in 1 week.
Okay, understand. Thank you. Thank you for your time, sir.
You're welcome.
All right. Next up is Stacy.
Hi, Dr. Langer. My name is Stacy. I'm a fellow New Yorker.
All right.
Yeah. Born in the hospital, so I watched the show. I was on watch and wait for 15 years with 7 left cerebral meningiomas. One tumor was over my motor cortex, and it grew and it encroached on my sagittal sinus area. So they recommended a craniotomy so we can biopsy it as well. I had my full resection this past November, and on Tuesday, I will actually be doing Gamma knife for the second tumor that has grown a little bit, which is interhemispheric, and it's on my right visual cortex. My mom also had a meningioma removed 23 years ago, and she's been fine ever since. But my aunt has 3 meningiomas on my mom's side as well. Now, the question is a little bit unrelated, but I think it's a question all of us want answered here. I did over 20 rounds of IVF and IUI in the last decade. And I wonder if you believe that the IVF and any hormone replacement therapy, since we're all around that perimenopause, menopause age as well, triggers growth. I'm not sure about multiplication of the tumors because the 7 of them have been around for a while, but could there be any connection?
Yeah, I get to the other woman about IVF treatments. Look, the trouble is there's a lot of overlap. Women get them, especially young women. A lot of women are of childbearing age are on IVF, and then they get found out. Obviously, there's an issue with receptor status and whether some of these hormones. Put it this way: hormones can't help the tumor. I wouldn't think.
Right.
There's not going to be a benefit. But if you want to have children, and meningiomas are benign, so if it grows, you take it out and you still do the IVF. If it really accelerates the tumor growth for some reason, then you have to be super careful. It's something maybe unique to you. But you only have about 20 years or so that you can safely have children, and when you get into your 40s, the risk of pregnancy goes up, and so you have to determine what you got to count your balance the risk. And I would say that that's something you need to discuss with both doctors on both the neurosurgeon and your in vitro gynecologist, and go from there. But obviously, if this thing's really growing, they're probably going to want to hold off on the hormones. But if everything's quiescent and stable, then I would say do it.
Right. No, definitely. I think I'm past my stage, but I know that they did grow during that short period of time while I was the IVF. It was like we did have a little bit of a growth spurt. So definitely. Well, thank you so much.
You're welcome.
Thank you. Thanks, everyone. I'm going to go last with my question of the day. I'm Angel from Los Angeles, California. 10 years ago, I had an incidental finding of an 8-millimeter tumor, meningioma. And after 6 years on watch and wait, it grew to a 2.1 centimeter, and it was over the motor cortex, butted up against that main SSS vein, and then at that point became a tumor that had to come out. As you say, is it a can or a must? And mine was a must. I saw 4 neurosurgeons in the area, and they all agreed it needed to come out. So I was very fortunate on both ends. I didn't have any symptoms before going into surgery, which is crazy to me that I had a craniotomy and never had a single symptom. And I'm also a success story in the sense that post the surgery, I really never had a deficit, which is nice. I do obviously have fatigue and worry and just some anxiety around kind of monitoring this for the rest of my life and making sure it doesn't come back. But I am very fortunate. So my question to you, Dr. Langer, is as time passes and your patient load increases, obviously you have, more good and bad outcomes. How is your job going for you? Is it getting easier or harder to manage?
I think it's harder. I think we're human beings, and throughout your life, you get better and better at what we do, and you still have bad outcomes once in a while. And I think one of the most frustrating things is when you do everything you can, and you're as good as it gets, and you still struggle with these things. And you start to get more fearful. At least I do, and I think it's an emotional business. So. And so if you're human, I think you can't help but be affected by that. Unfortunately, we have a lot of narcissist sociopaths in neurosurgery that, do it for a variety of reasons. And, I feel like I'm not like that. So the answer is, yeah, the threshold to operate goes up, the concern goes up, and, you have to be, we consider all the risks, and I'm becoming more careful and more conservative as I've gotten older.
Gotcha. Well, I speak for all of us when I say that we think you wear a cape, not scrubs. We appreciate that you are our superheroes. Again, your commitment to do this work is so very valued among all of us companions in this room. And if we can be of any support to anyone in your networking community, please do send them our way. Thank you.
If you could definitely make sure that our patients have your, you just email you? Is that how they get involved with the organization?
Yeah, they can email me, and I'm happy to send you kind of additional details. But none of us want to be in this club, but we're here, and we're grateful to be peer support to one another. Our Zoom groups have been very valuable to all of us, and we continue to see it grow. And we just want to support anyone out there who feels alone and scared and anxious, pre, post, watch and wait, all of the stuff in between. As you can see, we're all kind of on a different journey, but we all get it and kind of can be there for each other. So it
looks like most of you have done really well. Obviously, some have had setbacks that are chronic, and I think these groups really help in that situation. I'm going to make sure my patients and our department's patients are aware of this great group, and obviously it spans the entire country. So hopefully get a few more New Yorkers in there. But hopefully they'll be talking. The other thing is people who don't do well or have problems are the ones that tend to, be regretful and get involved. And so, the truth is people do well sometimes in the rearview mirror and they kind of like forget about it. And I think it's important that people who do recognize that, a bad outcome or a setback is something that's unfortunately happens. Hopefully groups like this and honest physicians and even working with psychologists, psychiatrists, or other functional doctors, neurologists, you can get ahead of some of the side effects from some of the unfortunate outcomes that you've had. And I think it's a team approach when it comes to that, and you have to pursue it that way. So I really appreciate the opportunity to talk, and I'll even be able to make my dinner. This is great.
Okay.
Well, we appreciate you. Keep doing the good work, and we'll definitely be following you. So thank you for your time.
Thank
you.
Thank you. Dinner.
So much. Have a good dinner. Enjoy your family time.
Thank you.
Bye-bye.
Thank you.
Bye.